Well, good afternoon, everybody, and welcome back to the United Regional Chamber's weekly update. We try to bring you on some interesting guests and some interesting subjects. And as most of us know, October is Breast Cancer Awareness Month, and it is my pleasure to bring on Dr. Latif from Sturdy Health. She is an oncology specialist, and I hear from Justine she's just a super great person. So we're going to put that to the test. Dr. Latif, how are you today?
Good, thank you. Thank you so much for having me, and I hope I can live up to that.
Well, Justine's right in the room, so she'll give you the look if you're not. First off, tell us a little bit about you.
So I'm a practicing medical oncologist and hematologist. I've been working here at Sturdy Health for about 8.5 years. I primarily focus on women's health. So I have a special expertise in taking care of women with breast cancer. But a lot of what I do is also working to help prevent breast cancer. So I do run a high-risk clinic here as well for women who are identified as being at increased risk for developing breast cancer over their lifetime, and really focus on what they can do to help decrease that risk and stay as healthy as possible. I'm in charge of the breast program here, and I really love reaching out to the community. I'm so thankful for this opportunity, especially during Breast Cancer Awareness Month.
Well, a lot of us, especially guys, we don't know an awful lot about that. So I've got a couple of questions for you, and hopefully you can enlighten some of us and also inform some of the women out there what's really needed. So what are some of the risk factors for breast cancer, and how can one reduce their risk of developing it?
Yeah, great question. Such an important thing to be aware of breast cancer in the first place, just as you acknowledged. Breast cancer is is the most commonly diagnosed malignancy around the world, and the second most commonly diagnosed malignancy here in the United States for women. In terms of risk factors, I like to think about it as risk factors which cannot be controlled, but we should be aware of, versus risk factors that we can actually do something about. So one of the most important risk factors that we can't control is our sex. Breast cancer is primarily a disease that affects females, and it is 100 times more likely to develop breast cancer if you're a female versus a male. So that's important to point out, because not everybody is aware that breast cancer can affect males. And we absolutely do see breast cancer in males, but it's primarily a female disease in terms of the numbers. We know that there are reproductive and gynecologic factors that increase risk for breast cancer. The earlier a woman begins to have her menstrual periods, excuse me, and the later a woman goes through menopause can increase the risk of breast cancer. We are aware that the fewer pregnancies a woman carries, or the later age at which she first becomes pregnant, also increases the risk of breast cancer. Breast density plays another big role. Breasts are made up of glandular tissue, connective tissue or fibrous tissue, and then fat cells. And the ratio of the glandular tissue and connective tissue to the fatty tissue kind of is measured, and that's what we refer to as breast density. We know that women who have more dense breast tissue are actually diagnosed with breast cancer at a higher rate. And that's something that can fluctuate over time. It can be related to genetics, it can be related to age, and even sometimes diet. What are other things? So one of the major things that can affect breast cancer risk that, again, we don't have much control over is our family history. Just having a first-degree relative in the family tends to double the risk of breast cancer. Having multiple relatives just increases that risk even more. And then there are some women and men who have a gene that runs in the family, something like a BRCA mutation. And having those sorts of genes that can actually cause various types of cancers can certainly impact the risk of breast cancer. Other things that I always like to think about, and I want everybody out in the audience to think about, is whether you've had a prior biopsy of the breast that showed anything that's called atypia or atypical cells. Those are considered high-risk lesions, and although they are not breast cancer on their own, we know that women who have those findings in the breast are susceptible to an increased risk of breast cancer in the future. And then certainly a prior history of breast cancer itself or receiving radiation to the chest at an early age can certainly impact one's risk. So I actually want to talk a little bit about the risk factors that we can control, because I think that's where a lot of our lifestyle and prevention should focus on. We know that women who are overweight as they go through menopause and or after menopause are overweight have an increased risk of breast cancer. And we think that's probably related to elevated estrogen levels because our fat cells make estrogen. And those elevated estrogen levels seem to have some role in the development of breast cancer. So focusing on keeping the weight to the ideal range as much as possible can really make a big difference. We also know that exercising at least 150 minutes a week can significantly decrease the risk of breast cancer. Any sort of movement is so helpful, but really having a formal exercise routine is not only good for our health in so many different ways, but it reduces the risk of many cancers, in fact. So I always encourage my patients to be moving as much as possible. We also see a link between alcohol intake and breast cancer. So there is some data to indicate that women who drink 3 or more alcoholic beverages a week on average can develop breast cancer at a higher rate. So I always encourage my patients to minimize alcohol as much as possible, avoid smoking, and really, stick with a really healthy lifestyle. Low-fat diet seems to be key as well. We know that women who nurse, who breastfeed their babies, reduce their risk of breast cancer. And then lastly, I'll mention that for women who are found to have a really high risk of breast cancer, whether it's related to family history or genetics, or even prior biopsy results, there are actually anti-estrogen pills that they may be offered to reduce their risk. And for some women, especially with genetic changes that run in the family, they may even choose to have their breast removed to prevent breast cancer.
Well, what age would you recommend that women start to get the examination?
Yeah, so such an important question. In general, the American College of Radiology recommends that starting at age 25, women have a conversation with a provider. They should be getting clinical breast exams, so once a year examinations by their healthcare provider, in addition to having breast awareness, just being aware of their breast health, aware of their breast risk, and paying attention to whether there are any changes there. For women who are at average risk of developing breast cancer, which means a less than 15% chance over their lifetime of developing breast cancer, we recommend starting annual mammograms at the age of 40. These mammograms are with tomosynthesis there, or what's described as 3D mammograms. That's all we provide here at Sturdy as well. And that's recommended to be done on an annual basis to pick up breast cancers at a small size, a small stage, if something was to develop. Because we know that mammograms reduce the risk of death from breast cancer by 40%. And the majority of women can be cured of their breast cancer if it's found at a small stage. Now, this all depends on one's own breast cancer risk. And the reason I mentioned it's so important to talk to your provider in advance to come up with a screening plan is because some women are found to be at higher risk for breast cancer based on some of the factors that I mentioned already. So providers can actually do like a computer model where we input various information or various characteristics about our patients and can actually estimate the breast cancer risk over the lifetime for that woman. And although no model is perfect, it can serve as a good guide as we develop a screening plan that's right for them. We know that one size does not fit all here. So if that's done and we find that someone is at increased or high risk for developing breast cancer, that corresponds to a greater than 20% lifetime chance of developing breast cancer. Then in addition to the things I already mentioned with the annual mammogram and the breast exams, we actually recommend supplementing with additional breast screening, typically in the form of an MRI of the breast. So an MRI of the breast is typically ordered to alternate with a mammogram, so that every 6 months there is some form of imaging being done. And the purpose is to really hone in on the group of women who are at most at risk and really be sure that we're doing a sophisticated test that can pick up any small changes at a very early stage. For some women who can't tolerate MRIs, there is an option for ultrasounds as well, which can be a little bit easier if someone does have experiences with claustrophobia and things like that. And then lastly, I'll mention that I previously talked about breast density increasing the risk of breast cancer, but we also know that breast density can impact even the ability for us to pick up small changes on a mammogram. And so the more dense someone's breasts are, the harder it is for the radiologist to see a change, a small or subtle change on the mammogram. And so for that reason, women who have more dense breasts may be offered to have supplemental imaging with an MRI or ultrasound as well. Now, any test we order obviously comes with some risk or ramifications. There is always the stress of undergoing additional testing, potential cost, and the risk of false positives. Sometimes we do additional testing and we end up seeing something and we end up chasing it and it turns out to be nothing worrisome. So I think what's really most important is for each woman to have this conversation with their provider, understand what their risk is, and then develop a plan that makes sense for them based on their values and based on their health concerns.
All right. Well, you had mentioned a couple of different screening for breast cancer. How should a woman determine what screening plan is best for them?
Yeah. So I think a lot of this depends really on their breast cancer risk. So that's going to be based on the risk factors that I mentioned before, what their family history is, what their genetic results are if genetic testing was performed, and if they've had any abnormal, for example, breast biopsies or even a history of breast cancer in the past. So it'll be that that review that kind of helps to guide what screening program is best for them, whether they just need mammograms or whether they need additional imaging studies. One way that I think we try really hard here at Sturdy to help our patients as they navigate this is by offering a high-risk clinic. So if a woman or their provider identifies that they are at higher risk for developing breast cancer because of all of these various characteristics, then they can go to a high-risk clinic such as what we offer, and we actually review in great detail all the different risk factors, what we can do to change that risk, and then also design the ideal screening program for them. Other institutions offer it as well, and I think it's a really, really important way for women to try to be empowered and take control of their health.
Well, I know a lot of people are afraid to go to the doctor. They're afraid to get some of these examinations. What are some of the symptoms of breast cancer?
Yeah, so because we do such a good job identifying breast cancers at a small stage when women are getting screening mammograms, the majority of breast cancers actually are associated with no symptoms. They get picked up essentially when when that woman gets a mammogram, so they wouldn't have really even known that it was there. But that being said, sometimes breast cancers can grow more quickly in between mammograms, or if someone has a more aggressive type of breast cancer, they may feel a mass or a lump in their breast. They may feel something under their arm, like in their armpit region as well. So even if someone is not doing a monthly self-breast exam, they should be familiar with their breast, familiar with their body, and paying attention if there is something new, a new bump or something like that that comes up. Sometimes breast cancer can be associated with skin changes. So that could be thickening of the skin, redness, maybe an overlying rash, itching. Occasionally we'll see breast cancer associated with nipple discharge, and sometimes that can even be bloody nipple discharge. And then occasionally breast cancer can be associated with pain, especially if it's a faster growing mass or tumor. So what I always recommend is really any change in the breast or underarm area, anything that doesn't feel right, anything that's new. I always recommend that our patients reach out to their provider. They should always come in and have a physical examination and potentially get additional evaluations if it's needed. It's always better to be safe rather than sorry. A lot of times people come in and it turns out to be nothing worrisome at all. But what we never want is for somebody to ignore a symptom that could be very serious.
Well, with all of the new technology changes and all the upgrading of the computers, how has some of the treatment for breast cancer changed over the years with your experience?
Yeah, that's a great question. So, I will say that breast cancer treatments are changing and growing at a rapid pace, and it's really, really exciting. So, uh, years ago, breast cancer, was treated really as one disease. Anybody who had breast cancer, they were offered a very similar treatment, which often included a large surgeries. Oftentimes, people had their whole breast removed, maybe even more extensive surgery than that. They often had all of their lymph nodes under the armpit removed. They may have received a lot of radiation, so X-ray beams after surgery to try to kill any microscopic cells, and then often received chemotherapy as well. The purpose of chemotherapy in that setting would have been to try to kill any microscopic cancer cells that could have escaped the breast and could still be floating around in the body. And so the majority of women who are undergoing treatment for breast cancer were kind of treated in the same way and often received very aggressive treatments. And what we learned is that everybody's breast cancer is not the same, just like people are different, their breast cancers are different. And we really need to be approaching this in a very more, much more individualized, personalized way. So we can offer a precise course of treatment that is the maximum treatment that's needed, but no more. Right? We always want to treat the cancer, do everything we can to cure the cancer, but not lead to unnecessary complications or side effects. What's great now is that the majority of breast cancers that are picked up, especially on mammograms when they're relatively small, in terms of surgery, can be removed with just a partial breast removal or what's referred to as a lumpectomy. So it's a much smaller surgery. It's a day procedure. So it's a much less intense treatment. And oftentimes women can be very happy with the cosmetic results as well. Instead of removing all of the lymph nodes under the armpit, oftentimes we can remove just 1, 2, or 3 lymph nodes and achieve the same purpose. Radiation fields are much more focused, so we're not radiating as much of the body. And in some cases, women are actually able to skip or avoid radiation altogether. And then I think for me as a medical oncologist, some of the most exciting advancements are really in the space of medication treatments. So as I mentioned, oftentimes after breast cancer surgery, we offer medication treatments to try to prevent the cancer from ever coming back or spreading elsewhere in the body. Now we know that every breast cancer is different. We can really tailor those treatments. So for example, women who have estrogen sensitive breast cancers, which are the majority of breast cancers, we can offer anti-estrogen pills or estrogen blockers, which actually prevent estrogen from feeding any remaining cancer cells in the body. So these pills work really well to help prevent cancers, but are relatively well tolerated. And we have several options. Even if someone has side effects with one, we have a lot of different things we can do to help them. In terms of certain types of cancers that we see particular characteristics, for example, there's something called HER2, which is a protein that can be overexpressed in about a quarter of breast cancers. Those breast cancers are generally quite aggressive, but we now have a very specialized targeted type of treatment called trastuzumab or pertuzumab. There's a few different medications in this realm that actually target that specific protein. So instead of broadly giving something that just kills cells throughout the body, it really hones in on the problem in that breast cancer cell and targets just that cell. And those treatments work really well for that group of women. We have definitely been able to add to our toolbox. We have certain types of breast cancers called triple negative breast cancers, which historically we didn't have great targets for, but now we can add immune therapy as we treat them. So these are specialized types of intravenous medications, which actually harness one's own immune system to be trained to fight cancer cells. So that's really changed the game for a lot of women. And in general, we're giving less chemo than we used to give, because in the past, as I mentioned, when we would give chemo to, the majority of women who had breast cancers, maybe more than a centimeter in size, now we have ways where we can actually look at the DNA pattern or the gene pattern of breast cancers, and really understand the biology of the cancer, and we can really sort out, well, who really needs chemo and who can really avoid it. And so by doing that, we're really being much more precise with the medications we're giving, and to the people who we're giving it to. So again, we focus on trying to cure the cancer, but minimizing unnecessary side effects. And lastly, I'll mention, even for women who have breast cancer that has already spread throughout the body, the field has been growing so quickly in terms of the medications we have that can target and kill those cancer cells, really with the goal of trying to avoid or delay chemo as much as possible. Oftentimes, these women are able to take pills and or other kind of easier or more gentle treatments, and we can really try to contain the cancer and just help them live with it without it impacting their quality of life in a significant way. That's always been the goal, and I think we're doing a better job of that, every year.
Well, Dr. Latif, this has been super informative. I really appreciate you taking the time to come on. Hopefully the public will, pick some nuggets out of this, reach out to you, maybe set up some appointments to get checked out. Any final thoughts before we end up?
Yeah. So first of all, thank you again for this opportunity. I just want to encourage everybody who's listening to really think about their own health, empower themselves to, take control of the things they can take control of, speak with their provider. I think communication is the most important thing. Speak with your doctors, ask them about your risk, ask them what you should be doing to protect yourself. And yes, my number is there. If anybody has any questions, feel free to reach out to us. We'd be happy to help however we can.
Awesome. Dr. Latif, thank you. Justine, I know you're in the background. Thank you, too. We really appreciate everything that Sturdy Health does for our communities. We couldn't survive without you guys over there. So, folks, thank you once again for joining us here at the Chambers Update. Look forward to seeing you next week. We're going to talk to Jim Hawkins about the MCAS next week. Big shout out and thank you to James Friedman and the team over there at AACS, who puts up with me every week. And we appreciate our audience. Folks, thank you. Stay safe.
Thanks, everyone.